Now I request Dr. P C Manoria sir to come here, and I will also request Professor A.K. Das and Dr. Shashank Joshi, Program Director, to be here to felicitate Dr. P C Manoria sir. And I will request Dr. Sanjeev Phatak and Dr. Dheeraj Verma to read the citation for Dr. P C Manoria.
Cardiometabolic Medicine was very important, a dent in the cardiovascular with all our love ratings.
So it's indeed an honor to have with us Dr. P C Manoria, and the DIACARE is privileged to award Dr. Shrenik Shah Memorial Lecture for the year 2022 to Dr. Professor P C Manoria. Dr. P C Manoria is a director, Manoria Heart and Critical Care Hospital, Bhopal. He is former professor and head of the Department of Cardiology, GMC Bhopal.
He is an honorary physician to His Highness Governor of MP. He is the past president of CSI, API, ICC, and past dean of ICP, ICMU, etc. He is a past chairman of Hypertension Council of Asia Pacific Society of Cardiology and past vice president of SARC Cardiac Society.
He was awarded Lifetime Achievement Award during the WCC PC 2008 by Bharat Ratna Honorable Shri APJ Abdul Kalam. CIO at New Orleans, USA, Mega Specialty Award during Multicon 2018 organized by International Board of Medicine and Surgery, USA 2018.
Sir is Master Teacher Award recipient of in Indian College of Physicians in 2019. Netaji Subhash Oration Award in Epicon 2002. He was also recipient of the Award of Excellence in Academics Alumni PGI Chandigarh in 1997, Dhanvantri Award, CMI Con in 1997, etc.
He is organizing several national and international conferences for the last 40 years, and he has organized World Congress Cardiometabolic Medicine in 2019 and then again in 2022 in Mumbai.
Sir has edited almost 33 books and has published 74 publications under his belt in various international and national journals. He has delivered more than 800 lectures in various national and international conferences also.
So it is our profound honor to present you with the Dr. Shrenik Shah Memorial Oration for the year 2022. Thank you, sir.
At the outset, I would like to thank Dr. Bansi Sabu and his team for inviting me to deliver this prestigious Dr. Shrenik Shah Memorial Lecture. Dr. Shrenik Shah was also my great friend. I first met with late Dr. Siddharth Bhai Shah, and I also participated in the Hypertension Society of India meeting, which was organized by him at Ahmedabad. I have been interested, can I have the first slide please? I have been interested in cardiodiabetology and cardiometabolic medicine for the last 25 years or so. We published the first book on cardiodiabetology in API Kathmandu in 1996, and following this we have published 5 more books. But Dr. Bansi Sabu always likes to have deliberation on newer and newer topics. So today I am not going to talk on cardiodiabetology or cardiometabolic medicine. The topic which I have selected today is a new one. I am sure none of you would have heard on this. That is liver emerging as a big playground for cardiometabolic therapeutics. All of us know cardiometabolic diseases are rocking the entire world and are important contributors to cardiovascular morbidity and mortality. The peculiar feature of cardiometabolic diseases is they often conglomerate in the same patient. So it's not uncommon to have obesity, diabetes, MFLD, OST, and other diseases in the same patient. The most important thing is that the commonest cause of mortality in cardiometabolic diseases is ACVD, particularly acute myocardial infarction. And it is the desire of all of us, not even patients, that our heart should beat without blockages. And time and again, every day we see scores of patients asking us, do I have blockages in our coronary artery? What could be the simplest approach to achieve this goal? I'll be talking to you in a couple of minutes. Lipid management plays a very important role in reduction of cardiovascular event, but curiously enough, all drugs, rather most of the drugs, which decrease cardiovascular events, their site of action is not in the heart, their site of action is not in the arteries, their site of action is in the liver, and liver is emerging as a big playground for cardiometabolic therapeutics, which I will be alluding to. Most of the lipid modulating drugs, their site of action is in the liver. Liver is an important site for fat accumulation, and you cannot manage diabetes optimally without focusing on the liver. And some anti-diabetic medications also execute their glycemic action through the liver, and they have other benefits on the liver. So when we look at the lipid modulating drugs, what do we see? Statins, which are the foundational drugs for lipid management, their site of action is in liver and not in the cardiovascular system. They inhibit the synthesis of cholesterol in the liver. Fibrates, which decrease triglycerides, they inhibit the synthesis of triglycerides in the liver. Vamportic acid, which is a new blockbuster for additional lowering of LDL cholesterol in patients with ASCVD or HeFH, it also acts in the liver and inhibits the synthesis of cholesterol ahead of statins. PCSK9 monoclonal antibodies, which are the magic bullet for decreasing LDL cholesterol, their site of action is in the liver. Inclisiran, which melts cholesterol from the vessel wall, the site of action is in the liver. It inhibits synthesis of cholesterol, PCSK9 in the liver. Lomepatide, a drug for familial hypercholesteremia, also acts in the liver. It's an MTTP inhibitor and blocks the transfer of triglycerides to ApoB. Mepomarsin, which again is an antisense to ApoB, acts on the liver. Pelacarsen, which is likely to emerge out as a transformational therapy for LPA therapeutics induced cardiovascular disease, it also acts on the liver. It's an antisense to ApoA, decreases the synthesis of ApoA and therefore LPA. Evinacumab, which is a boon for homozygous familial hypercholesteremia, also acts on the liver, is an NGPLT inhibitor. And the beauty of this molecule is its action is independent of the density of functioning LDL receptors. PCSK9 monoclonal antibodies do not produce appropriate response in HoFH, but this is independent and therefore is a boon for homozygous hybrid. Gene editing, which is now coming in a real existence, is becoming a real reality. The site of action, the modulation is in the liver, and liver transplantation has been done in past. And now in the USA and other countries, fatty liver or NFLD is the commonest cause for liver transplantation. So you cannot ignore when we talk of cardiometabolic therapeutics in liver. Cardiodiabetology now is a well-developed specialty, but it seems that in times to come we will be forced to create this new subspecialty of diabetes, that is cardiohepatology, because everything is mediated via the liver. So why we are so much concerned about lipids? The first reason is cholesterol never sleeps. It works 24/7 and executes its ravages on the cardiovascular system in terms of formation of plaque. And all of us know plaques are the major culprits for CVD. They put at risk of heart attack and stroke. Heart attack is the number one cause of death, and stroke is the number one cause of disability. The second reason why we are so much bothered about lipid management is that during the last quarter of century, lipids management has reached great strides. And what are these? When we look at the issue, can we stabilize the plaque by lowering LDL? The answer is a big yes, and we have data from several statin trials. When we look at the issue, can we reduce the plaque buildup by lowering LDL? Answer is again universally yes. That is, we can arrest the progression of atherosclerosis, and reversal trial is a beautiful example. High intensity atorvastatin showed that the progress of atherosclerosis can be arrested. And the third issue, can we shrink the plaque by LDL lowering, which means can we achieve regression of atherosclerosis? Answer again is a big yes, and the Glugov trial is a staring example. When you lower LDL cholesterol to 65, it results in arrest of progression of atherosclerosis. When you lower it to 50, it results in regression of atherosclerosis. And can we make the plaque disappear by lowering LDL? This is obviously an unresolved issue at the present state of time. Maybe this may be fulfilled in the future. So as a consequence of all this research in lipid management during the last quarter of century, a very dicta has emerged that if you want to live without CVD for 100 years, keep your LDL less than 70 throughout your life, which means after 20s or 30s. And many luminaries in the cardiology who are in 90s are having their LDL 35, 40, 36, and so on. So one of the simplest way to achieve longevity of life, free of obesity, it has to persistently keep your low. And one of my great globally renowned hepatologist, when I was talking about this, said if you maintain your SGPT, SGUT within normal, you can also live for 100 years, because if the liver remains healthy, the cardiovascular system is healthy. There's a close cross-connect between liver and the cardiovascular system. So messages are very clear, only it is to be followed if you want to get rid of these deadly diseases. Statins, all of us know, it inhibits synthesis of cholesterol in the liver by blocking the HMG coenzyme A reductase. It is the foundational therapy for lipid management. All of us are aware of it. But just to recapitulate, it improves endothelial function, delipidates the plaque. You can see on a vascular MRI or near-infrared spectroscopy data from the yellow trial. It also has an anti-inflammatory action, can pacify these hot plaques which are seen on a PET CT, promotes calcification of the plaque, lot of pleiotropic effects. But what is not widely publicized, it also decreases thrombogenicity of the blood. 1 out of 10 plaque rupture culminate into an acute coronary event. So it is the thrombogenicity of blood at the time of plaque rupture which is important. If you are on statin at the time of plaque rupture, the probability of a plaque rupture culminating into an acute coronary event can be minimized. And they have a legacy effect beautifully shown by the Voskevs and the other trials. Bempedoic acid is a new blockbuster for additional lowering of LDL in patients with ASCVD who has not achieved their goals, or for HeFH. And these are the 4 clear trials. Whenever you have a clear, be assured that this is a bempedoic acid trial. And again, the site of action is in the liver. It's a prodrug. It gets activated by ASCVL1, as you can see. And this enzyme is not present in the skeletal muscle, and this is the reason why there is no muscle toxicity. It inhibits the enzyme ACL ahead of the statins, as you can see on your left. ACL means adenosine triphosphate citrate lysase, and inhibits the synthesis of cholesterol. These are the 4 landmark trials, and all of you are aware of it. And each trial has substantial number of diabetic patients, so this also applies to the diabetic population. LDL reduction with bempedoic acid, very easy to remember. If you are using on top of statins, because statins also act through the same pathway, it is 15% reduction plus minus 2. So you'll see all the trials. If you are using in statin intolerant patients, that is without statin, it will be 25 plus minus 2. And if you are using in absence of statin bempedoic acid, it will be 35. So it's very simple, 15, 25 and 35, and most of the trials, as you can see, show this dicta. The additional advantage of bempedoic acid is also decreases high sensitivity CRP, and therefore has an anti-inflammatory action which is beneficial. And unlike statins, this is not diabetogenic. Rather, it decreases blood glucose and also has a tendency to decrease weight. The only side effect being increase in the uric acid, which can be easily taken care of by drugs. Why we say bempedoic acid may be a game changer for lipid management? Because only 50% of patients with statin achieve their LDL goals. And if you use a triple combination, bempedoic acid, 180, ezetimibe 10, and atorva even 20, a publication from Australia has very clearly shown that the triple combo can reduce LDL by 63%. And if you are following the ACC guidelines for very high risk, 90% of LDL goal, 95% of patients achieve LDL goal less than 70, and if you are following the European, 58% achieve LDL goal less than 55. So triple combo is a great combo. In statin intolerant patients, never forget that some statin should be on board, because statin has a lot of pleiotropic effects, and pitavastatin, never forget, in statin is the easiest statin, usually doesn't have a statin intolerant problem. So this triple combo again is a great combo for a statin intolerant patient. PCSK9 monoclonal antibodies, we know they are the magic bullets for lowering LDL. They also act on the liver. The normal function of PCSK9 is to get bind to these LDL yellow curly receptors, so that if they get bind to these receptors, the receptor is taken inside the cells, and this undergoes lysosomal degradation and cannot be recycled. But if you neutralize it with a PCSK9 monoclonal antibody, as you can see, the receptors are free to bind to the LDL particle. The particle is taken inside the liver and is cleared off, and the receptor undergoes recycling, and there's increase in the number of LDL receptors. The reduction in LDL is phenomenal, 40 to 60% on top of anything, and they also decrease LPA. And this is translated into reduction in cardiovascular event. 4-year trial showing 15% reduction in the ischemic endpoint. Odyssey, post-ACS patient, again 15% reduction in the ischemic endpoints. And we have a panoply of PCSK9 trials in ACS, and we routinely use PCSK9 volocumab to affordable patients, and this results in marked diminution in cardiovascular events. The dicta is, if after an angioplasty you get recurrence of a cardiovascular event, the most common cause is your LDL has not been targeted to the appropriate level. Inclisiran, again, is a beautiful drug. It again acts on the liver, inhibits synthesis of PCSK9 in the liver, and melts cholesterol from the vessel wall. Is approved in the United Kingdom and several countries, likely to be available in the near future. But the problem is its cost. And a single injection, 300 milligram, lowers LDL by 50%, and this remains there for the next 6 months. So one injection, 300 milligram in 6 months is the way to go, and that's why we say the beauty of inclisiran is unmatched. 2 injections per year, but the cost is phenomenal. Again, lometride, which is for FH, also acts on the liver. It inhibits MTP and prevents the transfer of triglycerides to ApoB. So less VLDL means less LDL. Mepomersin, which is also a drug for FH, also acts in the liver, is an antisense to ApoB and decreases LDL. And this is again evanacumab, a boon for homozygous FH, also acts on the liver, and it acts even when the LDL receptors are not functioning, where PCSK9 does not act. All of us are aware of the reduced trials with icosapentaethyl carried out in patients with CVD or diabetes with risk factors, with hypertriglyceridemia 135 to 499. Great reduction in the ischemic endpoint, 25% in the primary endpoint, 26% in the secondary. But the problem is the benefit was seen even in triglyceride less than 150, clearly showing that lowering of triglyceride was not the mechanism of benefit in the reduced trial. There are several other mechanisms. Gene editing is emerging in a big way, and it seems that it is going to become a real reality in times to come. The first patient in New Zealand has already undergone a successful gene editing, a case of FH, and the Heart-1 trial with VERVE-101 is already in progress, and the plan is to treat 40 patients with FH. Gene editing is a big stick, because it's one and done, and you don't ever have to come back for treatment. So great therapy, but we'll see how it goes in future. So when we look at the evolution of lipid-lowering therapies at the present state of time, we have statins, which are the foundational drugs used in all patients as first-line therapy, and we have various combinations, ezetimibe, icosapentaethyl, bempedoic acid, fibrates. We have monthly or bi-monthly therapies, evolocumab, which is available in India, evanacumab. We have weekly or monthly pelacarsen, which is emerging as foundational or transformational therapy for LPA therapeutics, inclisiran biannually, PCSK9 vaccine is also being tried once in a year, and if this becomes successful, a booster dose every year will be the new way to target atherosclerosis, and gene editing is going to come in a big way, but let's see what really happens in the future. Now, anti-diabetic medications also mediate their action via the liver, metformin, pioglitazone, SGLT2, GLP-1. All of us are aware of it, that the metformin targets insulin resistance at the level of liver by decreased glucose output, also acts on the skeletal muscles. And SGLT2 inhibitors, which are the molecule of the decade, they also decrease insulin resistance, decrease inflammation, decrease FFA flux, and produce lots of benefit on the liver. And pioglitazone, which is again a time-testing molecule, a beautiful insulin sensitizers, also decreases liquid accumulation, decreases insulin sensitivity, and many other beneficial effects. It targets insulin resistance at the level of the adipocytes, also skeletal muscle. And GLP-1, again, receptor agonists, they also decrease glucose production. And as you can see, GLP-1 RA targets 6 of the 8 components of the ominous octet, and are wonderful drugs, only cost is prohibitive. So in summary, liver is emerging as a big playground for cardiometabolic therapeutics, and I'm sure cardiohepatology is going to emerge in a big way as a new specialty of diabetes in times to come, because you cannot manage or target diabetes without the help of the liver. Both are closely linked to each other. Most of the lipid modulating drugs for decreasing CV have their action on liver and not in the heart or the artery. You can arrest progression of atherosclerosis by lowering LDL to 65 and achieve regression of atherosclerosis by lowering LDL to 50. And if you keep your LDL levels below 70 for most of the life after 2030, you can live up to 100 years free of atherosclerotic cardiovascular disease. There is a great cross-connect between diabetes and liver. FFLD increases diabetes, diabetes increases FFLD. Diabetes cannot be managed without focusing on the liver. In fact, some of the globally renowned hepatologists say that it is MFLD which occurs first, that produces diabetes rather than diabetes producing MFLD. And many anti-diabetic medications, metformin, pioglitazone, SGLT2 inhibitor, GLP also acts on the liver. So thank you very much for the kind attention. And I'll again like to thank Dr. Bansi Sabu, who is a very versatile personality, and I'm a great fan of his and his team. Thank you very much for your kind attention.
Thank you, sir. Thank you, sir, for the wonderful talk. As sir gave the crux of the message that if you want to live for 100 years without cardiovascular disease, you have to keep your LDL less than 70 with the liver enzymes within normal limits. I request this hall to give the standing ovation to the sir, P C Manoria sir, for his wonderful lecture. Thank you very much, sir. Thank you very much, sir.